All right, well, we can go ahead and get started. So thank you everyone for being here today. My name is Iman Khwaja Reddick. We are pleased that you could all join us for this week's lecture in Volume 9 of the KnowNeuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the KnowNeuropsychology Board, as well as members of the KnowNeuropsychology Committee. Before we start our lecture, one of the main goals of KnowNeuropsychology is to provide free, high-quality didactic content to our audience. Every KnowNeuropsychology and KnowNeuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to KnowNeuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided within specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted through the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Joshua Mady for today's lecture titled Capacity Evaluation in Neuropsychology. Dr. Mady is a clinical neuropsychologist and assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Kansas School of Medicine, Wichita. He provides clinical evaluation services for adults and older adults, including individuals with suspected dementia or other cognitive concerns related to neurological, medical, or psychiatric conditions. Dr. Mady is also actively involved with the education and training of practicum students, interns, fellows, and residents at the University of Kansas School of Medicine, Wichita. So, Dr. Mady, I will go ahead and turn it over to you.
Great. Let me get my screen shared here. All right. Could I just get a verbal confirmation that the slides are present?
Everything looks great. Thank you.
Great. Awesome. I appreciate that introduction. Thank you so much. I'm really excited to be talking to everybody today about capacity evaluation neuropsychology. It is a area of passionate interest of mine related to my clinical work. And hopefully I will be able to share with you guys today kind of a foray or an introduction into what capacity evaluation may look like for us as neuropsychologists. So I don't have any financial disclosures, but one thing I do want to mention is I wouldn't define myself as an expert in capacity evaluation. And the reason why I do this is there's a few reasons. First, capacity evaluation has been a clinical interest of mine, and I've been able to receive training in it throughout my course of training, internship, postdoc, and I'm currently doing consultation as well, inpatient consultation with a local hospital service. But really, the vast majority of the materials and topics discussed during this presentation are largely built upon others' tireless work and efforts, and I want to make mention of that. The second reason why I wouldn't necessarily define myself as an expert is because this field is ever changing and there's always new things coming out. And really being on the forefront of that requires due diligence, and I really highly recommend that if capacity evaluation is something that you're interested in pursuing moving forward. So my overall objectives of this talk are to define capacity and capacity evaluation. There's a lot of ambiguous terminology that is present within the literature. Again, as this field is evolving, being able to really define that has been a challenge. I also want to describe potential roles as neuropsychologists in capacity evaluation, what that might look like given the specific context we work in or the specific types of capacity that we're asked to evaluate for. And then we're going to walk through sort of a vignette, sort of a case example of collaboration of the two, of medical decision-making capacity evaluation, which is just one of the types of capacity evaluations. So to begin, what is capacity? Again, there's this ambiguous terminology that floats around within the literature. It's capacity versus competence. What's the distinction between the two? When we talk about capacities, are we specifically talking about a broad set of abilities or skills? Are we talking about a very specific narrow function? What context is capacity defined in? What context within the law? Is it civil law, criminal law? And what context are we actually making our capacity determinations or evaluations in, clinical versus the legal context? So we're going to walk through these in a little bit more detail. So capacity, defined very simply, is the ability to make a decision or perform a task. And I really like that kind of simple distinction, and then we can build upon that as we define this a little bit more. When we speak of capacities, these are multiple task and context-specific functions, and we'll talk a little bit more about that. But our capacities are largely defined by civil law, so law that involves individuals' rights, autonomy, and interests, as opposed to criminal law. So I like this table from Moy and Marson paper in 2007, and this is an adaptation of that particular table. But you can see here on the left column, there's a variety of civil capacities that were defined at that time. And they essentially made mention of 8 total capacities. Capacity, again, further evolving and can be broken down a little bit further. And I think a couple of others have emerged as the field progresses. But looking at the right-hand side of that column, the scope of abilities required or the skills required can vary across the particular capacity in question. So for example, that first civil capacity of independent living, there's a broad scope of abilities that go into our day-to-day independent living. And it involves a broad scope of cognitive and procedural skills that go within that particular definition of independent living capacity. Now, when you compare that to the third one, treatment consent or informed consent or medical decision-making, depending on how we define that, that is primarily a narrow capacity or a narrow scope of kind of what goes into that particular capacity. It's primarily a cognitive task. So knowing the scope and the potential abilities required of any given capacity that we're asked to assess is highly important, especially as we define how we assess for these particular things. Now, there's a couple of contexts in which capacity is determined, essentially 2. So we have a clinical context and a legal context. Speaking a little bit more about the clinical context, this is the context that I myself as a neuropsychologist often am evaluating capacity in. So it's determined by my clinical opinion based on the relevant information that I gather. And it can result in a clinical action to either proceed or discontinue, depending on what capacity it is we're assessing. So, for example, with medical decision-making, proceed or discontinue treatment moving forward. A clinical determination of capacity does not remove an individual's legal rights. That's important to know. But as we'll talk about in a minute, clinical evaluation of capacity can move forward to a legal determination of capacity. So clinical determination can be legally challenged and overruled. If the court system goes through their process, they may not agree and they can overrule our particular clinical determination. So the legal determination of capacity, obviously defined and determined by a legal process, either through trial or through just a judicial hearing. And the important distinction to make is that when an individual is determined to lack capacity or have limited capacity, that does remove an individual's legal rights. However, this legal determination, we have to keep in mind kind of the intersection between clinical healthcare and law and how our decisions as capacity evaluators may be used within a legal context. So these legal determinations are often an undercurrent of clinical determinations. Now, when we compare that to competence, historically, these terms have been used interchangeably, capacity and competence. Now, competence previously was conceptualized more of as a global ability. So when an individual's competence or an individual is determined to lack competence, they may have been defined as an incompetent individual and really restricting the overall decision-making abilities and rights of that particular patient. However, there's been a shift in a couple of different ways. One, shift to use the term competence most often within the legal setting. So we can kind of think of some of the laws of competence that stand for like competence to stand trial. There's been an additional shift to, again, use the term capacity across both clinical and legal contexts, and to further define what we're speaking of when we're trying to assess for an individual's capacity or make a legal determination on an individual's capacity. So in large part, we're trying to shift away from this global perspective more to a very specific perspective. Now, that defines capacity a little bit further, but I want to talk about kind of some of the main features that go into the evaluation of capacity. So why are we doing this? Why are we evaluating capacity? Again, capacity evaluation and capacity itself is an intersection between ethics, law, and healthcare. And there's a couple of determinations that have made this more prevalent, or the need higher in today's society. A couple of things include our aging population. We have individuals who are living longer, who potentially are more prone or susceptible to specific disease processes that could affect their cognition and thinking, which possibly could affect their capacity abilities. So again, we have this larger population that potentially requires more evaluation of this. And the other thing that really has been an onus of why we're doing more capacity evaluations is kind of this need to make both the legal system and the medical system a little bit more efficient. So for example, if a patient comes into a medical setting and there's a question regarding their capacity to make a medical decision, we don't necessarily want to delay that patient's choice or designating a surrogate decision maker for an indefinite period of time. So we don't necessarily want to have this patient sit before a court, go through the full legal process to make that determination, if really what we're concerned about is the patient's ability to consent to treatment in that particular setting. So we need to make the medical system a little bit more efficient. Likewise, we don't want to overburden the legal system, that every patient that comes through our doors that may potentially have concern regarding their capacity would have to sit before a trial or a jury to make a determination upon that. So again, it's kind of a balance to make the two a little bit more efficient. Now, in terms of financial capacity, another kind of driving force is there's been a huge transfer of wealth over the generations, and there's been an increased challenge to an older adult's ability to potentially draft a will and transfer money from one individual to another, which can be referred to as testamentary capacity. And so there's a lot of kind of driving forces that have made this pretty much relevant across the variety of settings that neuropsychologists practice it. Now, speaking a little bit more about the ethical piece, capacity evaluation seeks to balance a couple of things: autonomy on one side, and then what I term as safety, but we can kind of think of as maybe beneficence, non-maleficence on the other side. And it's important to kind of know what context we're starting from. And so within kind of our westernized medicine and law within the United States here, autonomy is weighed much more heavily than, what that particular decision that we may be able to make has consequences for. And so it takes a lot of evidence to outweigh an individual's autonomy, as demonstrated here by this scale. Now, that depends on the complexity of the decision or the task. So we might shift that fulcrum of that scale depending on what it is we're actually supposed to be assessing for. So thinking again in the context of maybe medical decision making or informed treatment, the first example here, starting a trial of an antidepressant. So depending on the particular antidepressant and characteristics of the patient, presumably low risk with potentially moderate benefit. So again, our scale is really tipped to outweigh autonomy over safety, and we'd really have to demonstrate a significant need for a lack of capacity if that patient were to express, one choice versus another. Now, a procedure such as receiving a carotid endarterectomy, where the surgeon goes into the carotid artery and removes plaque, we have an elevated level of risk with potential moderate benefit, depending on kind of what we're trying to treat. And again, that fulcrum shifts to where the autonomy and safety may be balanced in a different way. And so we have to take into consideration the complexity of the question that we're being asked to assess. Now, there's a couple of fundamental elements that have arisen within the literature, specifically with decision-making capacity. So Grissom and Applebaum's seminal work looked at case law. So they went back and extracted these four fundamental elements from a variety of case law related to decision-making. And they found these four elements: so understanding, appreciation, reasoning, and choice. I'm gonna break these down a little bit more. So understanding, does an individual understand the relevant info that is being presented to them? Appreciation is, can they take that relevant information and apply it to their personal situation, appreciate how it applies to them? Reasoning is their ability to effectively engage in weighing of pros and cons related to whatever the decision is in question. And then choice is kind of the lowest bar of the fundamental elements of decision-making capacity. Can an individual express a choice? Can they communicate a choice? I think often our thoughts may go to an individual with expressive aphasia due to stroke. They may not be able to verbally express a choice, but there's a variety of ways that they can communicate. And so if we can demonstrate that they're able to do that, then we can move on to assessing the other particular elements. Now, again, these were extracted when looking at decision-making capacity, but these elements have been implied across a variety of capacity evaluations. So we can think about decision-making in general, as being important for financial capacity or independent living capacity. So when you look at the literature, try to kind of find out where these particular components are arising from the particular capacity that you are assessing. Now, despite that we have kind of a little bit more of a definition and structure regarding, what goes into decision making, it's important to note that capacity definition changes by the jurisdiction that you're in. So going back to the law piece of it, capacity, or an incapacitated individual or a person who has been deemed to lack capacity, is really set forth by state statutes or state law. And these are the two states that I currently hold licenses in. And I know this is a really wordy slide, but I wanted to highlight a couple of things, thinking back to those fundamental elements of understanding, appreciation, reasoning, and choice, and see kind of how it plays out within the particular statutes as it's defined. This was taken from guardianship law, And the Nebraska statute mentions that a person needs to have sufficient understanding and communicate responsible decisions. So it kind of maps on, maybe if you stretch a little bit, the Kansas statute's a little bit different. So it's an adult whose ability to receive and evaluate relevant information and then effectively communicate decisions. So maybe a little bit more defined. I've got a bias. I'm in Kansas right now. The other thing I want to highlight within the Kansas law, and largely you might be able to see clauses across whatever states you're practicing in. But Kansas has a specific clause written into it that says if an individual is being treated by prayer in the practice of their spiritual cultural beliefs, if that's the only thing we distill their question about their capacity down to, we cannot deem them to lack capacity. It's a clause that's stated within that particular statute. So the thing that I want to highlight is become very familiar with your state laws and statutes related to surrogate decision-making capacity and guardianship. So moving from the elements of capacity evaluation into what we might do as neuropsychologists. So why us? What important characteristics do we have that would kind of set us up to be able to evaluate capacity? Well, first, we're clinicians, and often within those statutes, physicians and psychologists are often deemed to be able to determine capacity. We'll talk a little bit about some variability when it comes to medical decision-making capacity. But from when a clinical decision then moves forward to a legal determination, really the folks who are often able to weigh in on that are physicians and psychologists. The second, maybe a half step away from clinicians, is we're evaluators, meaning we often use a variety of tools at our disposal. We have an understanding of the properties of those particular tools, including the strengths and weaknesses, and using and integrating a lot of information to come to a determination, whether it's a diagnosis or a capacity determination, and using that information to then recommend treatment or course of action moving forward. But the thing that I think really sets us apart is we receive direct training in neurodevelopmental, medical, neurological, and psychiatric conditions that are often associated with a lack of capacity. So we really hopefully continue to build our knowledge about the patient populations and characteristics that might affect capacity and what that can potentially look like moving forward. So neuropsychologists also practice in a variety of settings that are conducive to capacity evaluations. So depending if we're in a clinical setting versus a forensic setting, it may dictate the type of capacity evaluations that we receive. So for example, I mentioned I'm clinical. I don't do any forensic work at this point. And I largely evaluate for probably medical decision-making being the first, independent living being the second, and financial capacity being the third. However, if you're in a forensic setting, you might often be asked to evaluate testamentary capacity or an individual's ability to derive a will regarding either finances or property and estate, things like that. And then also, it kind of depends on the setting that we are in, whether inpatient or outpatient. So inpatient work often tends to be a little bit more rushed, time crunched, and requires a little bit more of a flexible approach compared to, let's say, a comprehensive outpatient evaluation, where we have maybe a little bit more time to determine the particular tests and administer those tests and gather additional collateral information. So we have to keep in mind, both within the setting that we're working in, the context that we're working in, the capacity evaluation can look very differently across these. So neuropsychologists, we love our tools, and we have a variety of tools at our disposal, including, our cognitive assessment that we're all very familiar with. as well as maybe functional or task-specific assessment, which we may also be familiar with. But one thing that we may not be as familiar with, especially if you're new to capacity evaluation, is capacity-specific instruments. I'm going to talk about kind of the implications of each of these within a capacity evaluation. So, sad to say, for neuropsychologists, there is no clear pattern for a cognitive domain related to capacity. Now, there's a caveat, and I'll talk about that in a second. But unfortunately, you can't just go into a capacity evaluation, administer Trails B, and then make a determination based on Trails B. That would not be competent or ethical work if you did so. But in general, the research does show that cognition is related to capacity, and various domains have been, excuse me, implicated in a capacity evaluation. So again, that caveat is it depends on the capacity in question. So a couple of research groups here looking at financial capacity found that written arithmetic was the primary predictor of financial capacity across healthy controls, individuals with mild cognitive impairment, and Alzheimer's disease. Within medical decision-making capacity, a lot of research has demonstrated that verbal expression, comprehension, loads pretty heavily on that understanding and potentially the appreciation component of decision-making. So it depends on the capacity in question. Don't assume that one MMSE score or one score on our neuropsychological measures equals a lack of capacity. Again, we are clinicians and evaluators, and we integrate holistic information to make our determinations. So we also have functional or task-specific instruments at our use to evaluate capacity. These are often used with independent living, financial capacity, and driving capacity, and largely because those often include procedural skills. So we need to know how an individual performs on the specific task in question. Now, there's caveats, depending on where we're administering that, if the administration environment is similar to the environment that an individual has at home. But again, we understand the strengths and limitations of our tools and hopefully incorporate that in a holistic manner. So there's a wide variety here. This is not a comprehensive list. I just threw some together to kind of get the juices flowing, thinking about some of the tools that we specifically use. I have actually used most all of these, aside from driving simulation or on the road testing. I've never participated in that. I know neuropsychologists do participate that in some facilities. Often I defer to occupational therapy for a driving evaluation specifically. Now, kind of moving down that list, we also have capacity-specific instruments. And again, this varies depending on the type of capacity that we're assessing and the type of tool that is being used. And most of the research has shown some tools available for medical decision-making capacity and financial capacity. Beyond there, it's a little bit more of a stretch, and more research is needed to be able to identify these particular tools that are capacity specific. But the first kind of set up here on the top, semi-structured or structured interviews, are just that. So it's a way to kind of formally structure your interview so you're touching on the relevant components related to the capacity question. Now, vignette-based instruments use vignettes that are independent of what an individual is presenting for. And it's a way to see how they may reason, appreciate, and understand relevant information to the vignette, which is, again, independent from what they're presenting with. So there's a combination of the two. You can actually see one of the capacity-specific instruments, the assessment of the capacity to consent to treatment, developed by Jennifer Moy and her colleagues, actually has a structured interview or a vignette base, and you can determine which one makes the most sense given the presentation of the patient. So this is the ACE. This is the Aid to Capacity Evaluation. This was a semi-structured interview developed by Etchells and colleagues, I believe in Toronto. And so this was actually mapped on to Canadian capacity law. However, there's a significant overlap regarding those elements of capacity and US law. And so you can kind of see the different questions. There's 7 questions in total. The 7th question has 2 parts, but it's really trying to assess the patient's ability to understand, to appreciate any foreseeable consequences or alternative treatment. And then, kind of specific to this one within this particular tool is the patient's decision affected by depression or psychosis? And it gives you some prompting questions. Again, it's a semi-structured interview that you can use to, again, formally assess for a patient's understanding, appreciation, and reasoning. One thing to keep in mind, though, as we do these types of evaluations with our patients, we want to make sure that we're also teaching our patients to the degree that we feel confident in doing so, as opposed to just assessing. So, for example, if we come into the evaluation for medical decision making, let's say it's an inpatient, and the patient is unsure why they're there, we provide that prompt, the opportunity for them to learn that information. And then we take that, and what we observe with their ability to learn that information, and then continue to assess moving. So it's not just a test, it's also providing some information and structure and support to hopefully make a more accurate determination. So there's obviously our tools, but equally, or maybe even more important, are other aspects of how we're conducting the capacity evaluation. So making sure we're doing thorough record reviews, that we're consulting with treatment teams if there is one available. Our clinical and collateral interviews, especially those collateral interviews, can be priceless in being able to determine, if an individual's cognition is impaired, and we can't necessarily generate the information we'd like. We need some additional information to weigh in on that. We also want to make sure we're doing psychological assessment. Again, going back to those depression, those psychoses questions from the ACE. I've run into a situation where an individual was clinically depressed, and that was affecting their ability to move forward with treatment and being able to get in and potentially help treat that depression in the moment to then restore their capacity to make an informed decision for themselves was important. And then again, as I said at the beginning, and I say now, and I'll say at the end, consultation is important. We want to make sure that we're consulting with others, whether it is our ethics boards, other psychologists, the medical, legal, and ethics teams, if available to us. I would, based just upon my experience, I wouldn't want to do this alone. I would want to make sure I'm involving all consultation that's available to me as necessary. So we have all these tools. We have some potential ways to move about capacity assessment or evaluation. One thing I just want to highlight with this slide here is there's actually been a lot of research. I just selected a few articles here. And the point I want to make is when we have an understanding of what capacity assessment is and have some structure, that actually supports the fact that we see inter-rater agreement. So these particular authors and studies looked at physicians' ability to assess for capacity before and after, kind of going through some training, understanding some tools, and they found that the inter-rater agreement increased with being able to have that structure. So again, hopefully this presentation is a good overview to get your feet wet, get you thinking about the available resources, get that structure honed in on so you can move forward with doing thorough capacity evaluation. So I'm going to shift gears a little bit here and talk about a medical decision-making capacity or capacity to consent to treatment. So this comes from the notion of informed consent. And what informed consent is within the medical field is that informed consent to treatment has to have a couple of different elements. It has to be informed, obviously, to be able to discuss the treatment risks and the benefits and any alternatives, including no treatment and what the implications of that may be. And it also needs to be voluntary. And this is an important aspect because informed consent can be rescinded or taken back at any point throughout a treatment process, even in the midst of surgery. I specifically remember a experience that I had on fellowship where I was helping conduct a WADA evaluation, and the patient unfortunately had a panic attack right in the middle of the WADA evaluation, and they wanted to stop the procedure. And my supervisor and I helped kind of assess and treat the patient's panic within the moment and got them back down to baseline so that then we could then reassess informed consent moving forward. And they ultimately decided that they wanted to move forward with the procedure. But it's important to know that that could potentially happen. And then informed consent, also, the individual has to demonstrate the capacity to consent. And this is where we come into play. So Sessoms et al. In 2011 had an article, a review article regarding medical decision-making incapacity. And they demonstrated or talked about some of the prevalence rates across either a particular population or a particular setting. So you can see here on the left-hand side of the column are essentially the populations that they looked at. The second to right-hand column is the percent of patients with incapacity. So you can see with general healthy elder controls, less than 3% of individuals were deemed to lack capacity, medical decision-making capacity. But this can increase, again, depending on the particular disease or condition that a patient may have or the setting that they're in. So it's important to know these base rates essentially so that we can make informed decisions based on them. One thing I want to highlight is you look at Alzheimer's disease and the percent of individuals with Alzheimer's disease, documented Alzheimer's disease, or presumed Alzheimer's disease, I should say, 54% were deemed to lack capacity. But I want to actually talk about the reverse of that. So 46% of these folks were deemed to have capacity. So it's important to note that diagnosis alone does not equal a lack of capacity. And what we may presume or assume as debilitating cognitive conditions, individuals can express choice and understanding, rationale, and appreciation. So keep that in mind, depending on the particular settings that you see your patients in. So here's the vignette. I'm going to briefly kind of go through this, and we'll talk about this in a couple of steps moving forward. But we have a 70-year-old white woman with a prior history of stroke who was taken to the hospital ER for altered mental status. And upon workup, it's found that she had delirium secondary to pneumonia or acute respiratory failure. And so treatment with oxygen and IV antibiotics was initiated. So during her hospital stay, she became more alert, though she questioned her current treatment plan. And she tried to pull her IV and she wanted to be discharged home. So you are consulted by the treatment team to, quote, determine patient incompetence. And I put that in there because, again, the terminology is evolving, it's ever changing. It's up to us to really help define, what the patient evaluation really is looking for. So where do we start? There's several frameworks out there, depending on the type of capacity, and I encourage you to explore those. I like this cure mnemonic taken from Page and Matthews from a particular book I'm going to talk about here in a second. But this cure mnemonic really kind of helps us center to define, okay, what's the situation? What are we currently dealing with? So complexity, how complex is the capacity in question? Well, we don't know because the referring provider said determine patient incompetence. So we give the referring provider a call. And we do indeed find out that they are specifically looking for medical decision-making, essentially the ability to refuse particular treatment. Now we need to determine how urgent is the answer needed, or urgency. We are in an inpatient facility beds are a resource. So we can have a fair confidence of believing that the urgency is pretty high in this situation. How much risk is the patient confronting? So if this patient does not move forward with the proposed treatment for delirium, they may become more susceptible to delirium in the future, may continue to have consequences related to a current undertreated delirium. So there might be a high level of risk within this particular question. What environmental resources are available or potentially available to help support this person? So let's say we find out that this person is married and their partner is, they have a really good relationship with their partner and their family. And we are currently evaluating them in the hospital. And depending on the hospital resources, we might have some resources to help this patient out if anything kind of pops up that would necessitate us to be able to restore or support her capacity. So this book here, Assessing Capacities of Older Adults, again, great resource. It's published by the APA. It's a continuation of the APA, the joint APA/ABA, or American Bar Association Handbook for Psychologists in the Assessment of Capacity for Older Adults. It's edited by Jennifer Moy, and it's got a lot of great information in it. But she talks about these kind of core principles. So again, while there may be some very specific ways to move forward with a capacity evaluation, I want to talk about these core principles pretty broadly. So the first thing we need to do is presume capacity. This should be our starting point. Again, we're balancing and weighing that autonomy more heavily and the right for an individual to make autonomous decisions for themselves. So this should be our starting point. We should assume that as we walk in to greet this patient, she has capacity to make the decision that she's requesting. We've already talked about this a little bit, but diagnoses do not equal inability. What do we know about stroke? Well, it can definitely vary depending on the type of stroke and the potential functional consequences of that stroke. Let's say for this particular patient, she had a stroke about 3 years ago, a left MCA stroke. She had a course of treatment within the hospital and then some outpatient OT/PT speech therapy. Her residual difficulties include slow processing and maybe occasional word finding difficulty. What do we know about delirium? Well, we know that delirium, again, can cause altered mental status. If left untreated, could potentially have some serious consequences, such as death. But we also know that with treatment, the potential underlying functional consequences of delirium can resolve over time. So we need to kind of keep that in mind with this particular patient. So the next principle is focusing on the abilities to do a specific task or decision. So again, narrowing our focus of what we're actually trying to assess. We called the referring physician. They said medical decision-making capacity for her right to refuse treatment. So we need to assess if the patient can understand her diagnosis, appreciate how this applies to her situation, reason and weigh pros and cons effectively, and express a choice. So we go in to the room and we find the patient in her bed. She's alert. Let's say she's fully oriented. She's engaged. We tell her, the reason and the nature that we are there. And we start to dive into those components of capacity. Do you understand why you're in the hospital? Can you tell me, what might happen if you move forward with the proposed treatment of delirium? What might happen if you don't move forward with the proposed treatment of delirium? And let's say the patient says, well, then I can just go home. And maybe that might be an opportunity for us to say, after consulting with your medical provider, they stated that if we're not fully treating the delirium, you might still be susceptible for pneumonia or, a return to the hospital or potentially more serious consequences. Oh, I didn't know that. That kind of maybe changes my decision a little bit. So again, it's not super clear cut in the assessment part, we need to make sure we're integrating a teaching part within our evaluation. Let's say we also find out that this particular patient kind of came to at a certain point within her hospitalization. And she said, I looked down and I saw the IV sticking out of me, and I have this huge fear of needles. And so I just grabbed that IV and I just wanted it out because all throughout my life, I've just had this really substantial fear of needles and it just makes me uncomfortable. I mean, I have a pillow over that arm. I don't want to look at it. I have to look away. It's causing me significant distress. So we find out that she's got some medical anxiety related to needle phobia, and that might be important for us to know in this particular context. So we go through that process of assessing those UARC components. Let's say that's kind of where we end up. And we give her, our favorite cognitive testing. We find that an estimation of her premorbid abilities was largely within the average range. We give her a brief screening instrument to look at her current cognition. She scored 24 out of 30 on the MOCA. Let's say she lost a few points for some of the executive, maybe the verbal fluency, maybe a naming point, but she was largely able to retain the word list. She was largely oriented. We give her trails A and B, maybe some relative reduced processing speed and some difficulty set shifting. We give her waist similarities, verbal expression. She's in the average range with that. So able to express or perform verbal abstract reasoning in that particular task. So we kind of have a sense of her cognition at this point. So we take those two pieces of information together and hold them. So going back to this, does she understand her diagnosis? Let's say she does. Let's say she can appreciate new information and how it applies to her. Let's say she can effectively weigh pros and cons because she has this new information, but maybe she still is a little hesitant to move forward, and she expresses a choice. So the next kind of fundamental principle is we need to support before we subtract. So what supports can we engage in to increase her medical decision-making capacity? Can we address any anxiety related to her treatment? Maybe that's all this is. Maybe she has some medical anxiety. And if we go in and help treat that, then she's in a spot where she can express her choices with a little bit more clarity. We also need to understand this next principle, that restoration is achievable. That even if there might be some difficulties within an individual's ability to make a medical decision or whatever the capacity is that we're evaluating, we need to understand that we could potentially restore an individual to the point where they do have the capacity. So we know that with continued treatment, delirium will potentially resolve within this particular patient, and she'll return to a cognitive baseline. We might be at that cognitive baseline given the history of stroke, but again, that's why cognition is only one point of that. And restoration can also happen in the moment with support. So again, thinking about potential treatment of anxiety with this particular case. So this next principle talks about going against medical advice. It kind of has a negative connotation to it. So refusing treatment does not imply a lack of ability. So we need to make sure that we know that refusing treatment is not the same as a lack of capacity. We need to understand what a patient's values are. Going back to that Kansas clause within the Kansas statute, let's say this individual wants to be treated through prayer, and that's how they have treated their conditions in the past. And we gather that through the patient and collateral information and really are cognizant of the patient's values and their cultural beliefs that might inform that. We also need to be cognizant of the potential treatment team values and the biases that we all come with. I've been in situations where when an individual was quote unquote going AMA, there was considerable bias placed on an individual's ability to do so. So we got to recognize that those two things are fundamentally distinct. So that seventh process or seventh principle is focusing more on the process rather than the actual decision. So we don't look at decisions as good or bad. That implies a judgment to those decisions, and that can depend on who we are and what the context is. Rather, it's the focus is shifted to how the individual made that particular decision, and if they demonstrate those fundamental components in general decision making. So we focus on the process rather than the outcome. So let's say everything worked out in the patient, ours, the provider's favor. This person has the capacity to make that decision. However, she elected to have some anxiety treatment in the situation to help with that medical needle phobia. And then she decided to continue the proposed treatment and elected that as her choice. But what happens when we have to make that determination? Well, medical decision-making capacity can be determined by nearly any provider. Again, from a legal perspective, physicians and psychologists are the ones that potentially can weigh in on that with clinical evidence. But any provider, without cognitive testing, without functional task-specific testing, can make that determination, capacity to consent to treatment. However, in my experience, it's often determined by an attending physician, whether that's through inpatient or outpatient referrals. And neuropsychology often takes a consultant role to be able to provide their determination that a physician may use one way or the other. So if an individual is deemed to lack capacity, then the next step essentially is we need to determine who will make decisions for this patient. And I'm not going to talk too much about that particular process, but it can vary. And really the general consensus, both from a clinical and a legal standpoint, is we want to place the least amount of restrictions on this patient in their ability to make decisions and who we designate and the potential rights that may be taken away from the patient. So if the first thought is guardianship, we need to back up and think about surrogate decision making, activated DPOAs, identifying co-joint decision makers. All of these things are relevant clinical approaches to medical decision making. Couple of additional useful points about medical decision making is, depending on our context, we want to try to potentially assess over time. Quite often, things like delirium within older adults within inpatient populations or inpatient settings often arise. And so we know that delirium can fluctuate. So if we are suspicious about potential delirium, it's advantageous to the patient that we assess over time. Another thing is to keep our reports succinct and based on available information and structure in a way that can be used by multiple parties, including the attending physician who may not necessarily have a full understanding of the elements of capacity. You're drawing on those elements that are defined by law because, again, this may be a product that moves forward with legal ramifications. So, structuring reports in ways that really address capacity at its core. So some final resources here. The APA has some great resources, particularly related to older adults. Again, capacity can be assessed across adult populations, even pediatric populations. There's a variety of capacity situations where that might pop up, especially in those transitional periods. Also, again, consult your local state guardianship surrogate decision-making laws to understand what the defining features of capacity are in your state. And here's a variety of books to potentially look at as well. Dive into the literature, become more familiar with this. My final thoughts on this, capacity evaluation is case specific. So the saying, once you've seen one capacity evaluation, you've seen one capacity evaluation, I think rings pretty true. And that's been my experience, that there's a lot of variability that goes in what we're asked to assess, the contextual factors of the patient, the environment, the setting that we're doing the assessment in. And there's still disagreement upon the terms, the frameworks, the tools, and the approach. There's no one specified approach to be able to assess any given capacity. But knowing what those particular approaches and tools are and having those frameworks in your back pocket is important so that you have something to draw on. Because again, that structure can potentially lead to better outcomes. So it requires our continued education moving forward within this ever evolving system and domain. And then also requires continued education within the systems we work. So, for example, again, I do some consulting work with a local hospital and doing like an in-service presentation where we come in and potentially talk about capacity and the components that we're looking at specifically as we evaluate that might be beneficial to the treatment team or the setting that we work in. So here's my resources. I'll pause just so you can pause the potential recording and take a peek at those, what they are. But I appreciate the opportunity to talk about this in a little bit more depth and open to any questions that anybody has.
Thank you so much, Dr. Mady. This was an incredible presentation. I know I learned so much from just the fact that we need to take into consideration the complexity of the question being assessed. I really appreciated learning about the fundamental elements from understanding, appreciation, reasoning, choice. And I did not know, this isn't my area, but just knowing that the definition changes by jurisdiction. That's really important. I'm happy that that was highlighted. And also being able to see some of these capacity specific instruments just to give us a hands-on look at what you can actually use. I feel like that was very helpful. So thank you so much for all of that. I know we're getting close to time, but we have some questions for you. Let's see. One question came in and it says, so this individual works in a hospital setting and does inpatient capacity evaluations. And they say that they typically put in a consult for patients' decision-making capacity. So how do you educate our medical colleagues that decision-making is a decision-specific assessment rather than an all or none phenomenon?
Yeah, and I would say that that has been a common theme across the inpatient evaluations that I have participated in, where our historical definition of competence, again moving back towards that particular terminology, was that it was this global thing, that if a person was deemed to be an incompetent individual, then globally they don't have the ability to make any decisions. And it takes some back and forth, and again, wherever you can to I think it momentarily calling the referring provider and really having that conversation back and forth, defining what are you specifically asking that this patient is demonstrating a need for a capacity evaluation for. But then taking a step back because one provider in a hospital system is one provider. And so taking a step back, thinking about the system, how can we support the system in which we work in having education or potential presentations, something like this, to define, we're specifically needing to look at this task because this is what law and our ethics suggest to make sure that it is most beneficial for the patient, but also balances their autonomy. So there's a couple, I don't have a great, you say this, um, but in my experience, having those immediate conversations, I always call the referring provider, even if I typically don't get medical decision-making capacity, I just get patient incompetence. So having that first and foremost call, I think, has been beneficial for me, hopefully will be beneficial for you.
Thank you so much. Another question is, what are the key differences to keep in mind when assessing for someone for return to independent living versus medical decision-making? And that is outside of taking things into account like OT and PT notes and thoughts.
Yeah, that's a great question. And those two, again, in my experience, those two often kind of come hand in hand with each other. So I will get referrals to assess for a patient who, let's say, lives on their own. They have been referred to, or they present to the hospital and undergo some workup, some treatment, and then they just want to discontinue treatment and go home. And there might be some concerns about their living environment that have led to their hospitalization. And so you have to tease those two apart first and foremost. That's my perspective. We have to make sure that we're assessing for each independently. They do have a lot of overlap, and we have to make sure we're assessing for each independently. So I often, within my those particular evaluations, I'll talk about um, assessment of medical decision making, depending on what the decision is, and then below that, assessment of independent living. And again, thinking about kind of the scope that goes into independent living, we want to make sure we incorporate OT, PT, and all that information. But we potentially are going to be using some different instruments to tease apart the most relevant features of those things. We might use some tools in co-joint with our occupational therapy folks who may be able to speak a little bit more towards basic activities of daily living versus instrumental activities of daily living. So we'll get some more context or task specific functional instruments as well. I would say in general, the key difference is I kind of think of it, one of the perspectives, I largely work with older adults. So I think of the IADLs that I'm typically assessing for my outpatient evaluations. And those particular components that go along with those skills, I want to make sure if possible, I can assess for those things. The other thing that's a little bit challenging is doing an informal bedside evaluation of independent living. And so it often requires that you're using information from other sources, such as OT, PT, all the relevant information that you can get. And then you focus on the parts that you can get and integrate those two things together. So maybe more succinctly, make sure you define each of those and then focus on the specific tasks relevant to each of those, and potentially including instruments that go above and beyond just typical cognitive assessment that we would use for something like medical decision making.
Thank you, Dr. Mady. We have some really nice questions coming in. Another kudos to you in terms of an excellent presentation, and this attendees asking for any recommendations for national organizations that provide CEs related to capacity, in addition to the books that you shared.
Yeah, so my understanding is that, again, the APA, that link that I provided in the presentation. So if you read the joint APA and ABA handbook for assessing capacity in older adults, they have 4 CEs available for reading through that, and I'm sure they have you answer some questions. But I think they also have a presentation that's worth up to 7 CEs, or it might be like a workshop, a recorded workshop that you can work through to get some additional CEs related to that. And capacity evaluation, again, is burgeoning. And so, all the national organizations that we may be part of, like NAN and INS and AACN, as neuropsychologists, likely have on an ongoing basis some CEs related to this.
Thank you so much. Another question for medical decision making. This individual has often felt uncomfortable in these cases, particularly when providers are asking about ability to consent to specific treatments. Could you speak about the threshold of acceptable responses? That is the reasoning aspect of this. Most of the time, I feel like if I do not understand the pros and cons of specific procedures, how can I expect the patient to insightfully describe them? I struggle because I often feel that the best person to evaluate understanding of specific procedures are the individual specialists.
Yes, I want to empathize with this individual, that pops up very frequently in my own work, and it's echoed by my colleagues as well. Knowing what specific questions to ask about a specific procedure is difficult when, the medical procedure we may not be very familiar with. Again, I try to look at these from the outset as, we are a collaborative consultant. And as soon as as soon as you open the door for me, I'm going to start asking you a bunch of questions. So getting some more information from the referring provider, who may be the attending physician, has been useful for me. So again, I can say carotid endarterectomy, and I can say that an individual may experience stroke, increased risk for stroke and heart attack. But if someone asks about the specifics beyond that, I'm a little bit out of luck. So I may use the information that I can garner from these specialists to help guide those particular questions. So one of the tools, the MAC-CAT-T, the MacArthur competence, the MAC-CAT-TT, that particular tool, what you do is you actually take some time beforehand to structure those specific questions so that you're extracting those components based on the information that you can gather with that regards to that particular medical decision. So that might be an approach to use. But backing up, it's really a difficult area that often kind of leaves us in a quandary of, how we can best assess for something that is a little bit amorphous, and that we ourselves may have limited information on. So consultation, working with your treatment teams, again, is really invaluable.
Thank you so much for that. And yeah, I think it's about asking those medical providers, what do you want them to understand? Like the core pieces in concrete terms, what do you want them to walk away with? I think that's great. This is a really nice question. How do you deal with language barriers and capacity evaluation?
Yeah. So we've already got several layers of complexity with capacity evaluation. And then if an individual presents with, has a language that we are not fluent in, it adds an additional barrier, and everything that kind of comes along with our assessments, using interpreters and translators if we need to translate particular information within our tests, or providing information back to the patient. Really, again, I don't have a great recommendation on this, but it comes down to making sure that you're allocating the appropriate amount of time to afford a ethical assessment of capacity. And that may require that you're working hand in hand with an interpreter on the back end or the front end, as opposed to just with seeing the patient, to making sure that information is readily available to the patient. Whether it's the information about the procedure or the treatment, or again, the specific tools that we're using to help assess for that. So yes, that adds an additional layer on top of this already complex situation that we got to be mindful of.
All right. Well, thank you so much, Dr. Mady. We appreciate your time and all of the incredible information that you've shared. This was such a great presentation, and we just thank you so much. And we're looking forward to sharing this with even more people. I know we have a lot of questions and people are really excited about this area. So thank you so much for taking the time and giving us extra time.
Absolutely, my pleasure. And thanks for the opportunity.